Usually when an alarm goes off in a building, there's a clear, logical reason, like a fire, a break-in, maybe a broken pipe.
Right, the threat is external.
Exactly. You find the source, you put out the fire, and you reset the system. But imagine if that building's own security system suddenly decided that the foundation of the building itself was the intruder.
Oh, wow. Yeah.
It just starts tearing up the floorboards, pulling down structural walls, while the alarm just blares endlessly. And no matter what you do, you can't just flip a switch to turn it off, because the system genuinely believes it's saving the building.
That endless, confusing internal alarm, that is exactly what it is like to live with the condition we are analyzing today, lichen sclerosus.
Yeah, it is a highly misunderstood, intensely misdiagnosed medical mystery of the immune system. We have this massive stack of clinical guidelines, dermatology reports, and women's health data in front of us.
Lots of data to get through.
So much data. And our mission for this deep dive is to decode what this condition actually is, explore the exact biological mechanisms for treating it, and answer a very specific, highly debated question for you. What vitamins are actually good for lichen sclerosus?
We see that specific question everywhere. I mean, when people are dealing with an intensely uncomfortable chronic condition, they naturally want to know how they can use diet and nutrition to, take back control.
Right, it's human nature.
Exactly. So today, we are going to bridge the gap between immune function, dietary support, and hard evidence-based medicine.
And we desperately need to bridge that gap because the sheer scale of this condition is staggering. The data points to an estimated 1 in 60 women presenting to a general gynecology practice having lichen sclerosus. 1 in 60.
It is a massive failure of early detection.
It really is. Yet so many people suffer in total silence for years, bouncing from doctor to doctor due to misdiagnosis.
Well, and while it predominantly affects postmenopausal women, it absolutely affects men too, and even prepubescent children. Across the board, the delay in getting a proper diagnosis is one of the most agonizing aspects of this disease.
Okay, so before we can even touch on which vitamins or diets fix the problem, we have to look at what the problem actually is on a cellular level. Because the very first thing the clinical data stresses, like usually in bold letters, is what lichen sclerosus is not.
Right.
It is not an infection. It is not contagious. You cannot catch it, and you cannot pass it to a partner.
Lichen sclerosus, or LS, is a chronic progressive inflammatory dermatosis. It primarily targets the genital and perianal skin, and the visual symptoms are highly distinct. Well, once a specialist actually knows what to look for.
The physical manifestation sounds incredibly painful. The reports describe intense itching, which often peaks at night, alongside these white, shiny patches of skin that eventually thin out to look like wrinkled tissue paper.
Yeah, the skin is literally losing its elasticity and structural integrity. And when it affects the perianal area, it often forms a classic figure of 8 pattern around the vulva and the anus. Because the skin becomes so fragile, it tears under minimal friction.
Which leads to those tiny blood blisters and microfissures.
Exactly, and severe discomfort.
So what triggers the body to initiate this localized destruction? The clinical consensus points heavily to an autoimmune origin. Like, in one clinic's data, nearly 30% of patients had a secondary autoimmune disease, things like thyroid dysfunction or vitiligo.
The key to understanding the mechanism here is the discovery of specific autoantibodies, particularly one called the ECM1 autoantibody.
ECM1.
Yeah, it stands for extracellular matrix protein 1. To visualize this, think of the basement membrane of your skin as the biological glue and rebar that holds the top layer of skin to the deeper tissues.
Okay, so the foundation of the building.
Exactly. ECM1 is a crucial part of that rebar. In LS, your immune system produces antibodies that mistakenly target and attack that specific protein, effectively dissolving the rebar in that localized genital area.
That brings us right back to the confused security guard from the opening. The immune system decides the foundation is a threat and starts ripping it apart. But wait, if this is a purely internal genetic or autoimmune glitch, why is there so much documentation about external factors making it worse?
Like tight clothing.
Yeah, tight synthetic clothing, friction, or even urine exposure.
That is where the pathology gets really fascinating. It involves a medical phenomenon known as the Koebner response.
The Koebner response.
Right. The underlying tendency for LS is internal. It is driven by those ECM1 autoantibodies. However, physical trauma to the skin acts as the catalyst. When the delicate skin is rubbed by tight clothing or irritated by the acidity of urine, It causes microscopic damage.
So normal body would just send regular repair cells to fix the micro tear.
Right. But in someone with lichen sclerosus, the immune system's signaling is corrupted. The body senses the micro damage and sounds the alarm, but instead of sending standard repair cells, the confused immune system dispatches a flood of those destructive autoantibodies to the site.
Oh, wow. So the attempt to heal a minor irritation ends up amplifying the autoimmune attack.
Exactly. The body tries to fix a scrape and accidentally detonates a bomb.
That is wild. But it perfectly explains why the dermatology guidelines are so strict about using emollient ointments.
Oh, absolutely.
Things like soft paraffin or coconut oil aren't just for moisturizing. They are acting as a physical shield. You use them as a soap substitute and a barrier to protect that vulnerable tissue from friction in urine.
You're preventing the Kopner response from ever triggering. You are trying to stop the initial microtrauma so the immune system never gets the signal to swarm the area.
Right. Okay, so if the root cause is a confused immune system overreacting, it leads directly to the core question of this deep dive.
Yeah.
If you're listening to this and dealing with the pain of an inflammatory condition, your first instinct is likely, hey, can I just feed my immune system better to help it think clearly?
Right. Can vitamins fix this? It is the most intuitive question to ask. If inflammation is the weapon destroying the tissue, shouldn't anti-inflammatory nutrition be the ultimate shield?
So let's break down the specific vitamins that constantly come up in the women's health clinics and dermatology discussions. Vitamins D, E, and A are the big three.
The big three, yeah.
The data shows vitamin D is absolutely critical for regulating T cells, which are the immune system's frontline soldiers. And there is a strong correlation noted in several studies, like many people with autoimmune skin disorders also show lower levels of vitamin D in their blood work.
We have to be very careful here, though, to separate correlation from causation. Low vitamin D is frequently observed in patients with autoimmune conditions. However, the data does not suggest that the low vitamin D caused the immune system to start producing ECM1 autoantibodies.
Right, so supplementing with vitamin D won't necessarily unprogram the immune system's glitch.
Correct. Supplementing with high doses of fat-soluble vitamins, like vitamin D, should really only be done to correct a deficiency verified by a blood test. You cannot megadose your way out of a targeted autoimmune attack.
But the clinical literature still highly values vitamins E and A for these patients, right?
Yeah.
Not as a cure, but for their specific mechanical functions in the skin.
Yes. Vitamin E and vitamin A are potent antioxidants. When the immune system is actively destroying tissue, that localized inflammation produces a massive amount of free radicals.
Unstable molecules.
Right, unstable molecules that cause further cellular damage. Vitamins E and A act as scavengers, neutralizing those free radicals. They provide the cellular building blocks the body desperately needs to maintain whatever structural integrity the skin barrier has left.
That structural support extends to the broader dietary protocols we found too. There's a strong push for a full anti-inflammatory diet.
Absolutely.
Upping your zinc intake, adding probiotics to balance the gut microbiome, and loading up on omega-3 fatty acids from things like fish oil or flaxseed.
The goal is to lower systemic inflammation in the body.
Right. And they also suggest cutting out processed sugars, alcohol, and, well, in some sensitive individuals, gluten.
Adopting those dietary changes gives patients a profound sense of agency. Keeping a symptom diary and eliminating personal inflammatory triggers can certainly help manage the intensity of flare-ups.
A calmer overall immune system is less likely to overreact.
Exactly. But we must be scientifically honest here. Vitamins and diet are supportive therapies. They do not shut down the specific autoantibody factory.
Okay, if I can map this out. Relying entirely on vitamin D and an anti-inflammatory diet for lichen sclerosus is like putting premium high-grade oil in a car.
Oh, that's a good way to look at it.
It helps the whole engine run smoother, it optimizes the system, and it prevents secondary wear and tear. But if your transmission is actively failing and grinding its gears to dust, the premium oil isn't going to save it. You still need a mechanic to rebuild the transmission.
That framing is spot on. Vitamins and diet are your daily maintenance. They optimize the environment. But to physically halt the structural destruction of the skin's basement membrane, you need a heavy-hitting intervention. You need the mechanic.
So if vitamins are the premium oil, let's talk about the mechanic. Who is the star of the show when it comes to actually stopping this disease in its tracks?
The undisputed gold standard of care is the use of ultra-potent topical corticosteroids, specifically a synthetic molecule called clobetal propionate.
The efficacy statistics on clobetasol propionate are wild, especially for a condition that is so notoriously stubborn.
Very stubborn.
One of the prospective cohort studies tracked 244 patients using this specific ultra-potent steroid. 96% of those patients saw significant clinical improvement.
And 66% became completely symptom-free.
Wow.
Those numbers represent a massive triumph in dermatological treatment, and it works because of the precise mechanism of the steroid. When clobetasol propionate is absorbed into the skin, it crosses the cell membranes and enters the nucleus of the cells.
Wait, it goes right into the nucleus.
It literally binds to the DNA and switches off the transcription of genes responsible for producing inflammatory cytokines. It paralyzes the localized immune response, physically forcing those confused security guards to stand down.
But you can't just slather it on like a daily moisturizer, right?
Yeah.
The clinical guidelines map out a very rigorous, highly specific tapering regimen.
Yes, very specific.
You start by applying a tiny amount, usually just a pea-sized drop, once daily for a month. Then you taper down to alternate days for the second month. Finally, you drop to twice weekly for long-term continuous maintenance.
That long-term maintenance phase is precisely where treatment fails for many people. It is human nature, you know? The patient goes through the first 2 months, the maddening itch finally stops, the skin starts to look normal, and they think, well, I'm cured.
Right.
So they stop using the cream and throw it in the back of the medicine cabinet.
And the data on why that is a terrible idea is incredibly stark.
Yeah.
One study analyzed patients who stopped treatment after their symptoms cleared, and they saw a 55.6% relapse rate.
Over half of them experienced a full return of the disease.
But for the patients who adhered to a proactive, biweekly maintenance steroid, like using omeprazole furoate twice a week, the relapse rate was 0%.
0% relapse is unheard of in chronic autoimmune conditions.
It's amazing.
It proves a crucial biological reality. The underlying autoimmune tendency does not disappear just because the skin healed. The twice-weekly maintenance steroid acts as a continuous, gentle brake on the immune system, ensuring those autoantibodies never get the chance to ramp back up.
Now, if you're listening to this and you've recently picked up a prescription for clobetasol, you might be dealing with a major point of anxiety that the British Association of Dermatologists explicitly warns about.
The warning label.
Yes, you open the box, you pull out the tube of this ultra-potent steroid, and the manufacturer's warning label, printed right on the side, says in bold print, "Do not use on genital skin." Why on earth are doctors prescribing a drug for genital skin when the box specifically forbids it?
It is a profound failure of pharmaceutical packaging, and it terrifies patients unnecessarily. That standard warning exists because healthy genital tissue is naturally very thin and highly permeable. If a person with healthy skin overuses an ultra-potent steroid, it causes the tissue to atrophy or thin out dangerously.
But a person with lichen sclerosus doesn't have healthy normal skin in that area.
Exactly. The pathology of LS involves the abnormal thickening, scarring, and hyperkeratinization of the tissue caused by the inflammatory cycle.
So the skin is physically altering its architecture.
Yes. In the specific case of LS, the ultrapotent steroid is the exact tool required to break down that abnormal hardened tissue and halt the cellular destruction. Under clinical supervision, with the correct tapering schedule, it is not only safe, it is the only way to save the tissue.
So it's a calculated intervention. You're using a powerful tool for a very specific structural job. But the clinical landscape is also expanding for patients who have incredibly stubborn cases or who have already suffered severe tissue damage. The data highlighted some emerging, highly advanced adjunct mechanics.
We are seeing a significant shift toward regenerative medicine in this space. Clinicians are looking beyond simply suppressing the immune system. They want to actively repair the architectural damage.
Okay, so like what?
One of the most promising therapies is PRP, or platelet-rich plasma.
How exactly does spinning down your own blood help repair autoimmune damage?
Well, blood contains platelets, which are essentially cellular reservoirs of growth factors. When a specialist isolates your PRP and injects it back into the damaged genital tissue, those concentrated growth factors act as a biological beacon.
Oh, I see.
They signal local stem cells to migrate to the area, stimulate new blood vessel formation, and kickstart the production of fresh, healthy collagen to replace the scarred tissue.
That's incredible. The clinical studies also highlighted Morpheus 8V, which pairs microneedling with radiofrequency energy.
Radiofrequency is another way to force a tissue reboot. The microneedles deliver controlled thermal energy deep into the dermal layers. This precise heat creates micro-injuries that intentionally bypass the Kovner response.
Wait, it bypasses it. How?
Instead of triggering inflammation, the specific frequency of the heat denatures the old dysfunctional collagen and forces the body's fibroblasts to synthesize entirely new elastic structural proteins.
Wow. But to be clear, neither PRP nor radiofrequency replaces the steroid. They don't switch off the autoimmune attack. They're the construction crew coming in to rebuild the foundation after the steroid has finally silenced the alarm.
Correct. They are powerful adjuncts for restoring elasticity and reversing fragility, but the steroid remains the non-negotiable anchor of treatment.
Which brings us to the ultimate stakes of this deep dive. We know what LS is, we understand the vitamins are the premium oil, and the steroids are the mechanic. But why is this rigorous, lifelong commitment to treatment so absolutely critical?
We have to shift from talking about symptom relief.
Right, like stopping the itch.
Exactly. We have to look at the severe long-term prognosis of untreated lichen sclerosus. If the disease is allowed to progress unchecked, the continuous inflammation fundamentally destroys the architecture of the human body.
It's devastating.
In women, this severe scarring can lead to the physical fusion of the labia minora, where the inner lips literally meld together, often burying the clitoris beneath dense scar tissue. It also causes a rigid narrowing of the vaginal opening.
And for men, the architectural destruction primarily targets the foreskin, causing a tightening and scarring known as phimosis. In both men and women, these structural changes make intimacy excruciatingly painful.
Often impossible.
Yeah. And it can create severe obstructions that make passing urine incredibly difficult.
The physical disfigurement is terrible. But beyond the architectural changes, we must address the most serious clinical consequence: the cancer risk.
Yes, the epidemiological data confirms that patients with lichen sclerosus face an estimated 5% lifetime risk of developing squamous cell carcinoma, an aggressive form of skin cancer.
A 5% risk of genital cancer is not a statistic anyone can afford to ignore.
No, absolutely not. The pathology reports describe a very specific pathway for how this happens, referred to as DVIN, or differentiated vulvar intraepithelial neoplasia. Neoplasia essentially means abnormal, uncontrolled cell growth. It is the direct precursor to a tumor.
To understand how chronic inflammation turns into cancer, we have to look at the biological concept of immunological escape.
Wait, immunological escape? That honestly sounds terrifying. Can you walk through exactly how that happens in the body?
Sure, think of your localized immune system as a dedicated surveillance team. Under normal conditions, T cells are constantly sweeping your tissues, looking for mutating or abnormal cells, and quietly eliminating them before they can form a tumor.
Oh yeah, like security guards on patrol.
Exactly. But in a patient with untreated lichen sclerosus, the local environment is a chaotic war zone. The immune system is entirely obsessed with attacking the basement membrane and dealing with the massive influx of inflammatory cytokines.
So the surveillance team is entirely distracted by the fire alarm.
Precisely. Because the local environment is so overwhelmed by the chronic inflammation, early squamous cell carcinoma cells, that DVIN neoplasia can effectively escape detection.
Wow.
They hide in the inflammatory smoke. Without the T cells keeping them in check, those mutating cells are allowed to rapidly multiply and progress into full-blown cancer.
So the inflammation isn't just scarring the skin, it is actively creating a toxic blind spot where cancer can thrive unnoticed.
Which is why treating LS is about so much more than comfort. It is about clearing the smoke out of the building. When you diligently apply that maintenance steroid, you are reversing the histopathologic changes. You calm the environment so the immune system can actually resume its normal surveillance duties and spot real threats.
And the clinical evidence provides a massive sigh of relief here. Consistent adherence to that twice-weekly steroid regimen not only keeps the itching away and prevents the architectural scarring, it significantly plummets the cancer risk back down to baseline.
Yes.
You are literally dismantling the environment the cancer needs to grow.
It proves why lifelong monitoring by a specialist and routine self-examinations are mandatory. If you are maintaining your treatment but notice a new lump, a persistent ulcer, or a thickened area that does not respond to the steroid, you cannot wait. You must have it evaluated and potentially biopsied immediately.
So if you came to this deep dive hoping to find out which vitamin protocol cures lichen sclerosus, here is the scientifically grounded reality. Vitamins like D, E, and A, combined with a robust anti-inflammatory diet rich in omega-3s and probiotics, are fantastic, empowering tools.
Very empowering.
They are the premium oil. They scavenge free radicals, they give your body the building blocks for a resilient skin barrier, and they lower systemic stress. But they are the sidekicks. The true hero, the ultimate mechanic for lichen sclerosus, is consistent medically supervised treatment with topical steroids.
Absolutely.
That is what physically switches off the autoimmune destruction, preserves your anatomy, and protects you from cancer.
As we wrap up our analysis of the clinical data, there is one final, truly mind-bending hypothesis from the research that challenges everything we know about this disease.
Oh, yeah.
We established earlier that the immune system specifically targets the ECM1 protein in the basement membrane.
Right, the autoimmune glitch.
But one of the dermatological papers proposed a radical question. What if it isn't a glitch at all?
Wait, what?
What if this entire destructive cascade only happens because chronic, low-grade inflammation somehow exposes what researchers call previously sequestered site-specific skin epitopes?
Sequestered site-specific skin epitopes.
Okay, in simple terms.
In simple terms, these are hidden microscopic fragments of the skin's architecture that the immune system was literally never supposed to see.
So the immune system isn't randomly attacking a familiar protein. It's attacking because a biological curtain was accidentally pulled back, revealing a structure it doesn't recognize as self.
Exactly. If that hypothesis holds true, the future of autoimmune dermatology might not rely on suppressing the immune system with heavy steroids.
Okay, then what? If we know the immune system only attacks because these specific epitopes are exposed, future therapeutics could act as a biological invisibility cloak.
An invisibility cloak.
Yeah.
That is wild.
Instead of paralyzing the security guards, a targeted treatment could simply pull the curtain back over those proteins, re-hiding them so the immune system goes back to ignoring them entirely. It would completely redefine how we cure localized autoimmune disease.
It is incredible to think about where the science might go next. We've navigated from confused security guards and premium oil to the cutting edge of biological invisibility cloaks. Keep asking the hard questions, keep looking for the mechanics that work for your body, and most importantly, keep learning.